I just wanted to briefly, for those who've been sitting here catching these videos that we've been playing, we have in partnership today also with the Mighty, which is an amazing Mighty web organization, I guess. They're a web-based organization who they are a community for people with chronic illness, chronic pain, mental illness. They are amazing. They are incredible. They have 30 million views per month, something of that nature. But anyway, they are phenomenal people doing phenomenal work to give people, real people with real experiences, a voice, a place to express themselves. So I can't encourage you enough to check it out. It is an amazing resource. So this is a couple of videos they compiled for chronic pain, and I'll continue to show these during the course of the day. Here we are moving on to our second part of our program, and this is amazing. I can't believe the people we have here. It is a deep honor to have these incredible people here. And speaking of incredible, we have an incredible panel coming up, and to dive more deeply into the National Pain Strategy, and to lead that is the amazing Christin Veasley. Here you are.
So if we could ask our four panelists to come up and take a seat, that would be great. So as I mentioned earlier, the design team very early on felt like taking on the work of 6 full work groups in a one-day meeting was really a bit too much. And we really wanted to focus around changing pain care. And these were the 4 areas that we felt really needed to be addressed. So we've asked these 4 panelists to come and speak on each of the work group topics. I'm going to ask that each of them give, I've been told, a 30-second introduction. Okay, so they could probably all take about half an hour to describe themselves and all the work that they've done, but they could briefly introduce themselves and just mention, please, the work that you do that's most relevant to the NPS and the work group panel that you'll be covering. And then each of them are going to be giving some introductory statements, and then we'll take questions and answers. So Wayne, would you like to start?
All right, so I'm Wayne Jonas. I'm a family physician and a researcher, and I now work for the Samueli Foundation and Southern California Foundation, interested in integrative health. And we'll talk a little bit about what that is later. I did want to mention, this is fantastic. I really enjoyed the overview that you gave this morning in the discussion. Thank you very much for this. I will mention that the DoD actually had a pain strategy about 2 years before the IOM report came out. It was almost identical, at least in spirit and principle, to what was described in that, and they consider themselves first out in that, and the VA is pretty close behind themselves in implementation field. And so we work quite a bit with that, and just make sure that's on the table to look at as we move forward.
Good morning. I'm Roger Fillingim from University of Florida. I'm a clinical psychologist by training. I spend most of my time now doing research. I direct our Pain Research and Intervention Center of Excellence. I'll be talking a little bit about some of the disparities, recommendations, and targets that we have. I've been doing research related to ethnic group differences in the experience of pain for many years now, and I had the privilege of serving as the co-chair of the Disparities work group for the Federal Pain Research Strategy, which you heard Sean and Chris mention. So I'm delighted to be here.
Good morning again. Sean Mackey, I'm the Division Chief for Pain Medicine at Stanford. I oversee the clinical educational and research missions. I'm a fellowship program director. I'm the NIH postdoctoral training director. I spend most of my time doing research these days. I'll be focusing on most of my comments around prevention and care and what we're working on doing at Stanford to help advance many of the strategic goals within the National Pain Strategy.
I'm Steve Richeimer. I'm the Chief of Pain Medicine at a very faraway location, USC, about 2 miles from here, but it can take hours. So Similarly, I oversee the pain program at USC and the fellowship program. I'll be talking to you a little bit about pain education, and part of that includes our project. You'll see flyers out front for this to offer clinicians of all stripes a certificate or a master's degree in pain medicine, entirely available online. So we're trying to get the mission out there.
Good morning, everyone. I'm Diane Hoffman. I'm a law professor at University of Maryland Law School, where I direct the Law and Healthcare program. And my relation to this topic is that for a number of years, I was a Mayday Fellow, which is a foundation out of New York City that funds a lot of research on pain treatment and management, where I was looking at legal obstacles to the treatment of pain. And I published on insurance coverage of different varieties of interventions for pain treatment, looked at the role of state medical boards in facilitating or challenging pain treatment, looked at the laws, criminal laws, and prosecuting physicians for prescribing of opioids, and also looked at disparities with respect to pain treatment, with looking particularly at women and how they are treated for pain. On this panel, though, I'll talk a little bit about the law as an obstacle to the treatment of pain, but also law more as a tool that we can use to help move forward the agenda for pain treatment.
As everyone is speaking, if you have questions, jot them down. Again, related to your work and moving forward, those types of things we're going to talk about in depth this afternoon in the focus groups. And just think about questions that you may have about areas that the speakers are talking about. Dwayne?
So thank you very much. So I was asked to talk a little bit about service and delivery. A lot was said already in that area. And so I'll just try to highlight a couple additional issues in those areas. So I'm a family physician. I see pain patients in a integrative pain clinic embedded within a family practice, primary care. And I didn't hear a whole lot about primary care, but primary care is where pain management occurs. I'll talk a little bit about examples of patients that have platinum level health care, full coverage, all reimbursement, et cetera, and end up in a lot of chronic pain and addicted and other types of things because we don't have an integrated system. We don't have an actual system in which people are working together along the lines of what you described, Sean, in terms of your team. And I think this is the key issue. If I think about what works, we have a fair amount of evidence to know what works in clinical studies, and even some of the mechanisms behind that. But what we don't have is that we don't know how we can make it work, how we can actually make it work in the delivery system, and this was, I think, mentioned. Lots of challenges in that. I think about the residents that I train, both medical students and family medicine residents. They're not getting the training necessary to do the kind of non-pharmacological approaches to pain management. They don't practice in an environment where they have more than about 20 to 30 minutes to do that, including the teaching time in those areas. The patients that walk into the clinic certainly know what you mean by, tell me where it is on a scale of 1 to 10. That was extremely effective. That got the public very knowledgeable about pain. It helped make pain a vital sign and probably drove, actually, some of the opioid have right here. So actually unintended consequences are a huge issue. So a couple things that we're doing at the Samueli Foundation and the medical education side. We've provided University of California, Irvine with a large grant to try to reorganize its entire healthcare system, medical, nursing, pharmacology, and public health around whole person integrative care. That's a year in, and they're making progress in that area. We hope other schools will follow. And we're looking for the opportunity for other schools. Janet Napolitano was at the one-year anniversary last night at the celebration of that, and she even used those terms, whole person integrative care. So starting to get the concept out there. We are supported AAMC in coming up with prizes and hopefully a conference that will occur next year on excellent educational programs within medical schools around non-pharmacological approaches to pain and opioid management. So hopefully that will lead to some standards and competencies that can spread through that organization. I really think it would behoove us all to look at what the VA is doing. I'll mention it briefly. They're really doing a radical redesign, or attempting to do a radical redesign here, called whole health. Very, very different than incremental stuff that's been going on before, that involves health coaches, involves group visits, involves team care, involves behavioral components. I think that is an experiment that we should pay close attention to, since about 70% of residency in medical education actually occurs within VAs around the country. And then finally, I think ultimately we've got to fix primary care system. It's clear that the countries that have invested in and created effective primary care delivery that effectively reaches out and addresses some of the non-medical approaches or determinants of health, the social determinants, behavioral determinants of health. They have had much slower cost increases. They've had much better outcomes compared to the United States. And I don't know how long it's going to take us to get to the point, the breaking point, where we figure that out and figure out that we have to, in fact, invest in high-quality primary care, and that applies to pain and a variety of other chronic illnesses.
I do have a few slides. We're addressing the disparities issue in pain just by way of a definition. Disparities are preventable differences in the burden of disease or in opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So that's what health disparities are. And they are certainly relevant to pain. When people talk about health disparities, pain is not what immediately leaps to mind, but pain adversely affects population groups, and undertreatment of pain is more common in certain population groups. As you see here, women certainly are at greater risk for pain and undertreatment thereof. That's also true for racial and ethnic minorities, for older adults, for individuals in low SES brackets, and these are just a few of the population groups that can experience disparities in pain and its care. And if we're thinking about disparities, I think it's helpful to consider health system factors that can contribute to disparities and can help drive solutions, as well as both patient and provider factors. And then you see the intersection there in the middle of the clinical encounter, which is where, of course, the patient and the provider come together. And so we need to conceptualize these sort of three broad areas of impact on health disparities. So if we think about the system level, and Dr. Jonas was just mentioning some of the shortcomings of the system more broadly, a goal at the system level is to enhance access to high-quality pain care for underserved populations. And this means linking patients to available pain care. I would argue that we need better pain treatments, but that's down the road, frankly. Right now, we have a number of pain treatments that are safe and effective, but we need to connect patients to those treatments. We need to engage innovative methods in order to accomplish this, and that includes things like telehealth, web-based care, other ways of disseminating interventions to populations that otherwise aren't going to have access. And part of that might include decision support tools to help providers, and we could potentially build these into the electronic health records or other mechanisms, but help providers sort of aggregate and assimilate the abundant information that's available on a patient's clinical condition in order to make better decisions about how to provide them with care. And of course, we have challenges to moving forward in these ways. This takes some resources. we do need to continue to build the evidence base in order to provide the foundation for these kinds of initiatives. And it has to be a priority of our healthcare system, and at present, it's hard to argue that that's the case. That's system-level goals. At the provider level, and the NPS clearly pointed out the concerns about bias, whether conscious or unconscious, against certain population groups. And we need to directly confront this. There is work going on. Adam Hirsch in Indiana, among many others, are doing interesting work to identify where these biases come from and maybe to reduce these biases through education and other types of interventions. And we also need to provide training in enhancing communication, particularly with various population groups, and improve cultural competence among our providers. And again, the challenges here are in part around time and resources, as well as incentives. These things take time, and so we need to incentivize doing the right things and interacting with our patients in the right way. And most of my work has been spent at the patient level, just trying to understand what it is that the patient brings with them due to their unique mosaic that drives their response to pain and its treatment. And we've heard already about adopting a holistic approach to assessment and treatment, that is understanding all of the biopsychosocial factors that are contributing. We've also heard about the value of tailoring treatment based on patient characteristics and patient education and engagement of the patient in their own care. And these are going to be critical to addressing some of the patient-level factors that drive disparities. Challenges are we have an abundance of information, but relatively little evidence in the pain world of how to tailor treatment and what kinds of tailoring work well. And in fact, I think our research models don't do well with tailoring treatment, right? We like to put everybody in a bucket and apply a treatment to that bucket, and that's not what treatment tailoring is about. So we're going to need new models there. And of course, we've already talked about the system and provider level barriers that are in place, and those remain barriers even to addressing these patient level goals. So that's just a brief overview of system level, provider level, and patient level factors we want to consider. I do think it's clear that multiple factors contribute to disparities in pain and its treatment, and we can successfully address these things, but only if this is approached as a coordinated effort with all of the stakeholder groups in play, very much like we're trying to do here today. So I certainly applaud this effort, and this is what we'll need to do to move forward with addressing disparities.
All right. So the charge that I was given was to discuss aspects of prevention and care, and really how at Stanford, what are we doing to help advance those? So I'll beg your indulgence and allow me to be a little, if you will, narcissistic and Stanford-centric here in my next comments. But a lot of what I'm going to say applies to institutions and programs nationwide. From the very beginning, we've been focusing our strategic efforts around the IOM and the National Pain Strategy. As I mentioned, the IOM serves as this great blueprint. It gives us a sense on where we should go. And the NPS is this action-oriented document that tells us how to get there. So when I talk with our group, we have a large pain division. It's about 100 in our group. We're one of the largest in the country. We see, well, a large number of patients throughout the Bay Area. We use that as the overriding principles to help move things forward. So I'm going to go back to those overriding principles in the IOM and discuss them briefly. And what are we doing about those? So I talked about the value of comprehensive treatment and interdisciplinary approaches. And so we are continuing to see how can we bring team-oriented care to patients and do it more effectively, more cost-effectively, and also to integrate in the patient's voice in this. To that point about bringing the patients together, we have developed a patient family advisory council that's made up of former patients of ours who want to give back. And we have meetings with that group, who also are represented by staff and faculty, to help understand how we can do things better in our clinic, how we can do things better in our center. We talked about the importance of prevention, and that forms the basis for a large amount of our research activities. Chris mentioned this concept of primary, secondary, and tertiary prevention. We don't really get involved much here in primary prevention. That's preventing an injury from occurring in the first place. That's the area of workplace safety, of preventing hip fractures, if you will. What we got more involved in, all of us, is in the area of secondary and tertiary prevention, which is helping to prevent somebody after surgery or after an injury from developing chronic pain. Tertiary prevention, helping to prevent somebody who has chronic pain from developing into high-impact chronic pain. With regard to the wider use of existing knowledge and the collaborative effort for patients and clinicians, we have been holding every year an annual patient day where we have, on alternating years, we do a whole day of educational conferences. And I was listening to Cynthia talk about the efforts here with web streaming, and we web stream that globally, and those are all recorded and available on YouTube. And we get the patients engaged and integrated into those efforts. There's a call in the IOM for greater interdisciplinary research and then the translation to safe and effective therapies. And I think this is part and parcel of what we do. Our research in our group is all human-based. We're trying to understand the human pain condition, the individual differences that make up each of us, and how to translate that into predictive models that allow us to target specific, safe, and effective treatments for patients. We've done that through some of the work we've done in transcranial magnetic stimulation, a drug called low-dose naltrexone that we've published on, many mind-body therapies that we've developed, brief psychobehavioral interventions that we're now distributing broadly, and all for free, by the way. Finally, I want to spend just the last few minutes on what has become a personal mission for me over the last 20 years. And that's around this issue of data. You heard me mention the topic of poor quality data repeatedly. And this is what keeps me up at night, because what I am struggling with is this basic question of how do we really know if we're helping people get better? And what does better mean? And I'm reminded that unless we have good quality data about this, we're all just a bunch of docs with opinions at the end of the day, right? So much of what we do in medicine is all based on belief. It's based on in our opinion. And I've been driven by this mission to help provide better quality data for the clinicians and for patients. And so the Institute of Medicine, now the National Academy of Medicine, got into this, and they recognized the need for something called learning healthcare systems, which brings together science, informaticists, clinicians, patients, all around informatics, software platforms that collect high-quality data on every single patient encounter. And what I found is that it was a grand idea, but I didn't see a lot of activity in that space, and so I decided to go do that thing and build it. So back in 2012, we built and implemented a program called Choir, which we've been running now for 6.5 years. It's an open source, open platform, and free, my favorite four-letter F word, free, learning healthcare system that we've now disseminated across the country in a variety of different academic centers, as well as Canada and Israel. And it allows us to capture high-quality, high-volume data in every patient encounter, and to use that data for point-of-care decision-making, so that we have reports that we can share with you, with the clinicians, on how that person in front of you is doing, and use that to guide treatment. We're expanding that more broadly and into other clinical conditions, primary care, surgery, the perioperative space, you name it, and we're doing this in a collaborative way so that everybody's adding on to the source code, and as a consequence, our rising tide is elevating all of our ships. So our goal here is to be able to turn every patient encounter, every clinic visit, into something that is meaningful. In other words, to turn our clinics into research labs. Now, not research labs where we're experimenting on you without your permission, but research labs in the context that we're being very thoughtful and deliberate in how we're collecting the information and how we're using that information that will benefit the person who's suffering from pain. Ultimately, our goal is to develop this space of precision pain medicine, and then to, as I said, give that all away so that everybody benefits. So that's, I think, a little snapshot of what we've been doing up the road at Stanford. Delighted to answer your questions afterwards, but first, I think we're going to hear some cool stuff from Steve about the educational efforts they're doing at USC.
Pleasure to be here. Honored to be invited. For those of you who don't know Cynthia, if you're ever feeling down or down about yourself, call Cynthia. In no time at all, you'll believe that you're number one in the country. So thank you for that. You know, we're all here for the purpose of improving pain care. And I think it starts with what Sean was telling you about, which is research. You gotta know something, and you gotta get there through research. Then what do you do with that research knowledge? You gotta educate. And you gotta get the education to all the clinicians. And we have not done a very good job of that. So let me ask you some questions. Headache, a very, very common problem. According to some reports, it's the number one. In other reports, it's the number two complaint that patients come to their doctors with. What percentage of American medical schools have a mandatory coverage of the topic of headache, like a class on headache? Take a guess.
5% or less. 0.
A little bit better, a little bit better. 17% of medical schools, okay, have mandatory coverage of the topic of headache. Let's try pain in cancer. How many medical schools do you think have a mandatory, I don't mean a whole course, I mean covering the topic of pain and cancer?
30%.
Yes? 9%.
Oh my God.
How many medical schools in America have a mandatory course in pain? Yeah, 4%. So, you know, clearly we got a lot of room here. If we just take all pain teaching in medical schools in the United States, how many hours in medical school are devoted to teaching pain on average?
1.
Used to be, many years ago, we're a little bit better. 9. 9 hours out of 4 years. Yeah. Better. So in Canada, it's 19.5, so a lot better than us. And in Canada, they came out with a cover story of one of their journals about how your dog's doctor has more training in pain than your doctor.
It's true.
Okay. That's in Canada, which has 19.5 hours opposed to our 9. That's in medical school. I can tell you it's even worse. Pharmacy school, nursing school, physical therapy, occupational therapy, psychology, podiatry, all the other related clinical fields, it's even worse. In medicine, if somebody's interested, they can get advanced training by doing a fellowship, although, you know, tiny fraction of doctors ever do such a thing. And in a lot of these other fields, there is no such equivalent of that. So the problems we're facing are, how do we get more pain education to our trainees, to our students? And, you know, there's a bunch of people out there who are already practicing. They're not trainees or students anymore. How do we get education out to them? Part of this probably has to become embedded more deeply in the system, where medical schools, pharmacy schools, dental schools, et cetera, are convinced that they have to change their curriculum. I think some of that has to be mandated at state and federal levels. And licensure requirements for all these different fields probably have to start incorporating that pain is part of the ballgame. So I was asked to talk about some of the innovative solutions that are out there, so I thought I would share three, one of which is what we're working on. Sean earlier mentioned Scott Fishman at UC Davis. He and his team has put together a very innovative program of fellowship training for primary care doctors. So it's not a full-time, you know, one-year fellowship to become a specialist, but for people who are primary care doctors and want to get more advanced training through the UC Davis program, such a thing is now possible. Joanna Katzman has developed a program in ECHO. ECHO is an online mentoring system. So now there are primary care clinics, typically in rural settings, that can join the ECHO network and have online mentoring from pain specialists, also from other specialists in other areas, but we're focusing on pain. So if a primary care clinician in a rural area is seeing a patient that's difficult from a pain perspective, they can get online mentoring for that. And then our own program, which we only recently launched, is offering any clinician, nurse, doctor, dentist, psychologist, pharmacist, any clinician, a certificate, which is a one-year part-time program, or a 3-year part-time master's degree in pain medicine, fully online. So we were trying to certainly reach California, but we're trying to reach the United States and even international community, because as bad as it is in the United States, it's probably is worse in a lot of the rest of the world. We're hoping such a program can be available to all clinicians. By being part-time, we can reach those who are already in practice. We're looking at maybe even what's called now in the online world micro-credentials, where people can commit to smaller chunks. So maybe they just do 1 or 2 courses in an area of interest. What are some of the problems we're facing? Well, I'm at USC, and USC is not cheap. So lots of clinicians can't afford it. So we're trying to figure out how we can get funding, scholarship funding, so people not only in the United States, but again internationally, can get access to these kinds of programs. Would like to convince employers, healthcare organizations, Kaisers, et cetera, to sponsor some of their clinicians to get this kind of training. Another problem is, how do we get the word out? There's a lot of people out there who could use this, would probably want it, but how do we reach them? How do we let them know that these kinds of training programs are available? And then the last piece is, I said there's a lot of people out there who would want it. Unfortunately, there's a lot of people out there who need it but don't know that they want it. So how do we motivate people? How do we convince them that this is important, that this makes a big difference to the quality of their patients' lives? Those are some of the problems we're facing as we're trying to make this happen. So with that, I'll stop and pass it on to Ms. Hoffman.
Thank you, and I just want to also add my feelings about just being so honored to be on the panel with these other incredible speakers and to be joining Cynthia and John for this incredible summit that they put together, and also echo Dr. Richeimer's comments about Cynthia. If you don't know her, she is a force of nature, and despite her own challenges, one of the most positive people you could ever meet. So as I said earlier, I'm going to be talking about the role of law in trying to put together a pain strategy for California. It's not a separate focus of the National Pain Strategy, but in fact it permeates probably all of it, in that laws can be relied on to kind of change behavior. And so, unfortunately, laws can be used both to change behavior for good, but also law can be create challenges and have chilling effects on behavior that we'd like to encourage. And unfortunately, I think that some of that has been going on now with the opioid crisis. As a reaction to the opioid crisis and the CDC guidelines, which were meant to only be guidelines, non-mandatory, many states have now implemented or codified those guidelines as law. So we now have over half the states that have in place day and dosage limits on how much opioids are prescribed in those states. Also, the Drug Enforcement Agency and state medical boards have used the CDC guidelines as a kind of initial proxy or red flags for overprescribing, and have gone after physicians for that. And so these laws and enforcement practices are actually, I think, creating fear on the part of physicians, so that some of them no longer want to treat pain patients. And we've seen and heard even today about patients who've been abandoned by their physicians or have been forcibly tapered off of their opioids and are harmed by that. Some of those patients have resorted probably to prescription drugs or on the streets getting them, or have committed suicide. So the unintended effects of these laws have been particularly distressing. California is not one of the states that has codified the CDC guidelines, but the state medical board has engaged in some practices that I think may have also had negative effects. How many here have heard about the state board's death certificate project? And this has been an effort by the state medical board to do, going back 3 years, look at death certificates for patients and look at whether opioids have been listed as something that the patient was taking at the time of death, and then looking at any physician who had prescribed opioids to that patient and threatening them with disciplinary action, including fines of up to $1,000 a day if they failed to turn over the patient's medical records. So in response to this kind of activity, sometimes the law is necessary as a kind of a counter-corrective to mitigate some of the harms produced by earlier laws and enforcement practices. So what can the law do in these circumstances? So as a response to physician abandonment, patients can bring a legal action against a physician for abandonment. It's a malpractice violation. Typically, in most states, a physician has to give a patient 30 days notice before terminating them from their practice, and which is supposed to provide them with enough time to find another provider. But in fact, many patients can't find another pain physician who's willing to treat them in that amount of time. And if the patient is in a critical point in his treatment and they need access to medication, compliance with the 30-day notice rule may not be sufficient under common law. A state medical board can also charge physicians with abandonment. It's a considered unprofessional practice. Or a state medical board could issue a statement about abandonment and that it's inappropriate for patients on opioids. An example of an area where that has happened is British Columbia in Canada, where the state medical board, basically the provincial medical board, had come out with a standard of practice in 2016 similar to the CDC guideline. But when they heard reports about how this was harming physicians, they modified that standard. They amended it just this past summer to say that physicians must not exclude or dismiss patients from their practice based on their current use of or request for opioids or sedatives or a suspicion of problematic use of prescription medications. But in addition to being a tool that can be used to target specific physicians, the laws can be a tool for systemic changes. And here we might want to be using public health law. We've heard about that the national pain strategy was really modeled after public health approaches. And the law, the states have the power to use their public health authority to improve the health of their citizens. And public health tools range from, on the one end, using the resources of the state to come out with educational programs, public health programs. They can also require, mandate information reporting. They can provide subsidies or penalties or taxes to change behavior or mandate certain behaviors and have penalties for noncompliance. So the state has a variety of tools at its disposal in order to change behavior. So some of the things that the states could do, that California could do to be a leader in pain care through progressive laws and policy, I think would be along that spectrum. And while California already has progressive laws, such as the Pain Patients Bill of Rights and an intractable pain law, those laws don't, I think, really get at some of the systemic changes that you need. So some of these things have already been touched on that have been done by the private sector or academic centers. Things like establishment of a statewide registry for chronic pain. That Dr. Mackey mentioned that they already have a start of that at Stanford. Another public health approach would be to employ public health education strategies, public service announcements, social media, school-based programs, curricular design, pharmacy-based programs. These would be a budget item in the state public health budget. Also, the state could consider changing reimbursement for physicians. We've heard about that also from Dr. Jonas, how the current reimbursement for pain practice is very inadequate, that the complex problems that chronic pain patients bring to the table are just not supported by the current reimbursement system that encourages very short visits with patients. And things can be done to change that. Certainly it would be best done on the federal level. CMS could do this. They did something, it took years, but finally got in the CMS reimbursement for Medicare, reimbursement for physicians just taking the time to talk to patients about advanced care planning and how they want to be treated when they're terminally ill. But the state can do things with its Medi-Cal program in California or for state employees and their health benefits. The National Academy of State Health Policy came out with a report just a couple of years ago on chronic pain management therapies in Medicaid and focused specifically on policy considerations for non-pharmacological alternatives to opioids, and found that California was one of 29 states where the state Medicaid agency had not implemented specific policies or programs to encourage or require alternative pain management. A few other ideas: the state could require provider education in pain management, Again, something that is already being done in California. This could be expanded upon or required. Or the state could direct state medical boards to do something like the board did in British Columbia. Finally, the state needs to think probably about creative ways to get the money for this kind of thing. They could follow what California has already done for stem cell research and they've established a stem cell commission to fund stem cell research. Maybe they could do that for pain research. Or some states, I don't think California is doing this, but the attorney generals are suing pharmaceutical manufacturers with the idea that they contributed to the opioid crisis to help pay for some of the costs the states have had to treat addiction. Perhaps the monies in some of those states could also go to increase pain treatment programs. So I think these are just some of the ideas that we might want to focus on today. Thank you.
Thank you so much. It's always inspiring. I have the privilege to work with some of the best scientific and clinical minds in the country. And it's always inspiring, even though this is not the standard of care across the United States. It's always inspiring to hear from people who are at the top and doing the best work in both advancing research and caring for people with pain. So thank you very much.
Yeah, I was wondering if anyone has thought about doing anything about the workers' comp system, because I personally know 2 people in this very room who have begun having from chronic pain to intractable in that system, and it's really upsetting to me.
I'm on the California Department of Workers' Comp panel that helped put together the pain guidelines, the MEAC panel, and we don't do much workers' comp at Stanford. Stanford doesn't has a hard time contracting with workers' comp, but I felt a civic responsibility to try to put together some guidelines that would help those injured workers who have pain. And wherever I go throughout the state, I hear clinicians and patients complaining about the system and that the docs can't get approval for the treatments for their patients. The patients are incredibly stressed out being in the system. I'd like to see a reboot of it. I'd like to see some major infrastructural changes to it. Yeah, I think there should be recourse. I try to stay away from attorneys. You notwithstanding, but here's the thing, though. One of the most stressful things for people who are in this system is being in the system, and so that's why I'm a little reluctant to add lawsuits onto it. Is my goal is to help get people through that system as smoothly and as stress-free as possible. But there should clearly be some recourse for the patient. Dan, I think
Anybody else like to add to that?
Well, I was just going to say that is obviously one thing that is a state-level program as opposed to a federal-level program, so that it is something that the state legislature has oversight on, and it's something, I don't know, I'm not really familiar with the California system, but certainly, I know that I actually had a student in Maryland who wrote a paper on the workers' comp system and treatment of pain and opioids and how the employers and the costs of that, they were very concerned about treating their former employees who had become addicted and had to be treated for that. But I think that they're just, again, like other reimbursement systems too, they need to increase that, have resources for adequate care and visits to the physicians where they need care. So again, it's partly a resource question.
Yes, my question is mainly to Diane Hoffman. How can I advocate for my doctor so he can continue prescribing the pain treatment, which is opioids, for my wife's care? Because in your first statement, exactly is what's going on. The strong arm of the regulations are coming after my doctor, and they are getting out of the pain medication because of that.
Yeah, I think that I mentioned some legal tools, and if patients are harmed because their physicians are stopping seeing them, you can take legal action. But in terms of advocacy, I think you want to, you might go to try to meet with people at the state medical board. They are feeling pressure, I understand, by the whole effort to reduce opioid-based deaths. And unfortunately, I think the narrative around that is flawed, and that going after physicians for prescribing is not the primary root of the cause of those opioid deaths. So there's a story that needs to be out there about that. A lot more education also needs to go to our policymakers and legislators who are, again, it doesn't sound like California is as bad as some states in terms of actually codifying those laws, but physicians need a safe harbor in a way to be able to prescribe here in a way that's optimal for their patients. And Dr. Mackey, I think, probably has something to say.
Yeah, thank you for the question. And 100% agreed with everything Dianne said, and just to build a little bit on that, I think we need all of you to speak up. Go to your local legislators, have your voice be heard, because right now, up until now, most of the voices have been around the issue of addiction and people who have tragically lost a loved one, a family member, due to addiction, and that's all these legislators are hearing. California we're always on the edge of enacting some draconian policy that's going to make things worse, and a number of us try to beat that back. If we go just to our friends up the road in Oregon, I don't know if you heard, but their governor was looking to put forward a policy of zero opioids for Medicaid patients. So they were going to be taking Medicaid patients and weaning them off forcefully. All opioids. What that meant is that they were taking the most vulnerable population in their state and doing a forced taper on them without defining any specific resources. One of our faculty members, Beth Darnell, who felt so passionately about this, flew up to one of their meetings and testified. And I encourage you, it's on YouTube, and it turned into a Jerry Springer event where there were people, the board members were yelling at the patients, and the patients were yelling at the board members, and it was just it was a lot of drama, and in the end of it all, it doesn't look like it's going forward. So the point of that is, your voices work, so speak up. Thank you.
Thank you. Would anybody else like to add to that? Okay, we have another question. Please introduce yourself.
Hi, my name is Nicole Holland. I actually work for one of the medical device companies, and I know earlier we were touching on industry, and sometimes it gets a bad rap. And, I like to think about, industry isn't just pharmaceutical companies, opioids. It's, companies also working on minimally invasive treatments for patients in chronic pain that are options that are, quite frankly, drug-free. And I think a lot of times we're challenged with how do we educate the medical community, people around these other options that are available aside from opioids. I'm just curious for the clinicians, what do you see as being ways that we can help educate people when some of these options have been around for 40 years? Is there any room for improvement that you see?
Absolutely not.
Darn.
Sorry, I just wanted to see if everybody's awake. I think the timing is right for people in your industry because of the opioid crisis. It's driving it. I just got off of a FDA panel where they were looking to develop more public-private partnerships and actually putting out calls to industry to develop devices, technologies, with a focus on reducing opioid use disorder, but as a side benefit to also help pain. Tremendous number of opportunities to educate clinicians, educate patients, and we need to clearly get the word out about these additional resources. Steve, you do a lot of.
I mean, this is the educational problem that we're facing, and it's not only about devices, it's about how to treat pain well. And as I said, we don't necessarily even know all the answers, so we need the research. we have something to teach. And again, how we motivate existing clinicians to want to learn, to seek it out, and have programs available to them, that's maybe what some of our focus groups this afternoon can talk about. And then at the student level, at the trainee level, I think often our trainees and our students don't even know what they need to know. I remember when my kids were 5, why do I need to know how to do division? So they don't know yet, and it's the same in medicine often that, when you're learning, when you're training, you don't necessarily know what's important, what you need to know. So I think at a higher level, med school level, state level, American college, American Association of American Colleges, et cetera, we have to promote changes that change curriculum.
Thank you. Any other thoughts, Dr. Jonas?
Yeah, so it depends a lot on what you mean by devices. That's a very wide field. There's a lot of types of devices.
Oh, I didn't want to sway anybody. I was just curious. I'm talking about interventional, so like radio frequencies, sound stimulation, those sort of things, drug-free.
Right. Yeah, so devices are often seen as ways to get off of drugs or not have to use drugs because, it's stimulating endogenous growth, but still very, very wide. So in general, we love devices. Okay, all of my residents and physicians say this is great. Cold laser, CES devices for pain. We've got them in our clinic. The residents are like, hey, can I get trained in that? And can I offer that to my patient because I can do it in 20 minutes, right? It's simple, it's easy, it's an intervention, requires me to do that. So the issue is about the evidence. To get back to the evidence issues around that, we have a certain standard for determining whether a pharmacological intervention meets certain standards of evidence. For better or for worse, there's a ton of money in that. You can buy a p-value in those areas. It might have downsides. Difficult to do in devices. Many devices are ritualistic in the delivery, and so you go through a procedure which invokes a large placebo effect, which is really helpful for patients. So I don't want to get rid of them. But the evidence process will tell me they don't work. Okay? So I have a dilemma there in terms of deciding on how to do that. So I think it opens up a wonderful area for discussion about evidence-based medicine processes in those areas, replicability, where does the commercial groups come into that in terms of providing it, and that type of thing. So thank you for asking the question.
All right,
Do we
just
have any-
one quick comment on
Yes,
that.
please.
I just wanted to say, too, that, obviously evidence is the cornerstone to moving all of this forward, but interestingly, I was part of a meeting a few months ago, and one of the scientists there said, he asked a question and said, why would this patient stay on this particular treatment if it wasn't making him or her better? The problem is that we haven't included patients in the discussion about what better means, right? Pain is so variable, it's so subjective, there's a biopsychosocial experience that affects each and every person individually. And what we've learned, from some of these efforts as of recent is that it's not so much a number on a 1 to 10 scale moving from an 8 to a 7. Is that really meaningful to me as a patient? Because I could be drugged out on the couch watching television and I have moved from an 8 to a 2, but it's not meaningful to me at all as a person to be able to participate in my life activities. And so this is a major research issue. We can't continue to do the research that we're doing the way that we're doing it without helping and having some sort of effort where patients participate in what does meaningful clinical change mean to each and every person. And that's a key part of generating not just the high-level evidence, but in terms of what are these studies looking at and how do we define that for each individual person.
So, Chris, with the pain scale, rather than talking about a 0 to a 10, should we be talking about functionality? Are you depressed? Are you moving? What is your sex life? Are you thinking about suicide? Why aren't we talking about those things?
Right.
Because I always get, what is your pain level? And I want to say, well, what part of my body? and they just kind of do an average, but it doesn't mean anything.
Right. No, and this is being done at centers like Sean's and others that are here today across the country. But in terms of our federal system and how we evaluate efficacy and approval for pharmacologic and non-pharmacologic treatments, this has not yet been incorporated. So that's something the FDA is starting to look at and starting to get feedback from patients on what is clinically meaningful, what do companies need to track. But it's really a key question that a lot of times in this type of research we just gloss over. And we end up with another study that shows maybe a 1-point difference on the scale. And is it helpful? I don't know. Maybe for some, but not for others. And it's really a key issue that has to be looked at.
Thank you so much. We've got, did you want to add something,
Well,
Dr.
I'll just
Jonas?
say, but that'll buy you a new treatment if you have enough resources behind it. You could, I mean, maybe not a 1-point level on a 1 to 100 scale, but something that's considered clinically meaningful. You can purchase that, and it's easy. And I think that there are metrics out there around pain, like the Pastor Promise pain, which was developed by the Defense Department and the VA, which gets at functionality in a very rapid way. They don't even use it in the DoD, okay? They're not actually using it in the DoD because it hasn't been trained, in terms of how to use this and how to make that difference. So I think this is a key issue as to how do we talk about patient-centered care, but how do we get patient-centered research where we're collecting the information that the patients want that's relevant to them, not just rigorous in those areas. It's got to be both.
Okay, so just to let you folks know, I've got a question here, and then Heather, and then Cynthia, and I think that'll be our time for the panel.
So, hi, Greg Holgate again from Oscar Wellness. So Dr. Richeimer, this one's directed at you, but I think the whole panel could probably answer it. So you made a couple comments about medical school doesn't teach on pain. So what is it that they do teach really well that they didn't used to? And could we model education there to replicate that, to get it dispensed across medical schools? And then I think I heard at least the indication about vet schools and that they do a better job than that. Is that not a way to potentially look at how to dispense that kind of information and how to look at pain? Because animals don't have a placebo. Animals will either respond or not respond. And so I'm curious as to what your thoughts are in terms of educating on that, from looking at best practices and other ways of doing it, and can you extend that into current medical education?
Yeah, it's a good question and a good point. I think one of the shifts we've seen in medical education in the last decade is less silo-based, where you have your physiology class and you have your biochemistry class and you have your neuroanatomy class, and now there's that still exists, but there's still some effort to tie them together in clinical education. So they might present a case of diabetic neuropathy and bring into that the neurology sciences, the physiology sciences, the endocrinology sciences, and pull it together for the students in a way that makes clinical sense to them. So that's a technology that I think could and should be used in pain education. But we still have the problem of the motivation to do it. And I'm not 100% sure I understand why that's a difficult issue. Why, even though chronic pain far outstrips in terms of numbers cancer, heart disease, diabetes, all put together, why is it that the medical school curriculums focus much more time and resources on those than they do on chronic pain? Maybe some of the other panelists will answer that question for me.
Who else would like to jump in? And Chris, feel free.
Well, I'm certainly not qualified to talk about what medical schools do well or not, since I didn't go to medical school. But I think this is part of the cultural transformation that the Institute of Medicine report has called for. And part of that might be letting go with our obsession with death, right? That's the only outcome that matters, is postponing death. I think that's less true for our companion animals. I have a 15-year-old toy poodle. If all goes well, she'll die before I do, right? It's okay, but if she's suffering, that's not okay with me, right? On the other hand, it's not okay with me if my kids die before I do. So primary in the medical system's mind, and maybe in my mind, is making sure death happens in the right order. Now, I don't want them to suffer either, but all of the conditions you were talking about, Steve, are the ones that kill us, and that's what we've prioritized. Pain historically has been thought of as a nuisance and not a disease, and that was one of the most important pronouncements, I think, from the IOM report, was pain is a disease in its own right, you know, and so prioritizing quality of life, and now they provide metrics of quality adjusted life years. Pain reduces quality adjusted life years more than anything else on the planet. That's been clear from the World Health Organization, right? And so we're now recognizing that it's not okay just to postpone death. We need to increase health span and provide higher quality of life. And once that becomes the priority, pain wins. It really moves way up on the list. So I think that would address some of the motivational issues that we've been talking about.
Thank you. And Diane?
Yeah, I just wanted to echo something that Dr. Mackey said earlier, which is, I think there's some interchange between the schools and the testing requirements, the questions that are asked for licensing and board certifications, that to the extent that those who are making up those tests are going to be asking more about pain, and the USMLE focuses on that, that may get schools to make some changes in their curriculum.
Thank you, Diane. We have another question here.
I work with an integrative veterinarian who's constantly saying they don't have the same restrictions for patient protection. And because of that, they're actually able to try a lot of things innovatively and discover a lot of things faster. And he wonders if there's more, is there an opportunity to collaborate more with human integrative researchers? So this is kind of a two-part question. The other part is, I'm going to quote my former friend and colleague E. Rick Brown, who was very involved in the Affordable Care Act, public health leader. And he used to say, never underestimate the power of a single study to influence policy if it's something that lawmakers can understand. So my question is, two parts. One is, if you could design one single study that you think would have the most impact on the system, what would that look like? And the second part is, would there be a room in that study for integrative veterinary care to weigh in?
Great question. And if you could design one study, you only get one, what is probably the number one research question that I think is causing so much challenge? I think it's the question is, what is the long-term safety and efficacy of opioids in people with chronic pain? Right now, you look at the CDC opioid guidelines, and if you read them, by the way, they were meant as recommendations for primary care docs. That was the intended audience, and they were only meant as recommendations. They were not meant to be turned into policy, which is what they have been turned into. What they did when they researched the safety and efficacy of opioids is they only chose studies that were greater than 1 or more years in duration. Do you know how many studies there are out there of greater than 1 year duration on opioids? None. There are none. By the way, do you want? Well, we've now.
30-year study by Dr. Forreston.
What we're talking about is a large-scale randomized controlled trial. I have no doubt there are observational trials of people on opioids for a long period of time. But they were looking for what's called high-quality, high-level evidence. So they don't exist. Now, the obvious next question is, well, what's the long-term safety and efficacy of any of the treatments that we have? Pick your drug of choice. And the answer is there are no studies out there. So, they applied a rule, they applied a threshold to a particular drug that they didn't apply to any other treatment. And what we need is good quality studies to address that very issue. What's it like with somebody who's been on these meds for a year or for 2 years? Do they work? Do they not work? What does working mean? So that would be where I'd probably go for first if you wanted to make the biggest societal impact.
How large of a group would you have to have to do that?
Well, I think this gets into what you're trying to get at. And I've been focusing more of my work on effectiveness and external validation. And what that means is to try to take larger numbers of people with lower inclusion criteria that represent real-world people. I don't know about, Roger runs, has done a number of clinical trials. I am struck by all the clinical trials that we run that the people that get entered into the clinical trials don't look like real people. They're incredibly homogeneous, highly filtered. They have no other medical conditions, on no medications. And yet we draw inferences from these and we make policy. So I think you're seeing a lot of effort in this space with PCORI, Patient-Centered Outcomes Research Institute, that funds comparative effectiveness in real-world pragmatic trials. The NIH is putting more and more money into this idea of pragmatic trials. But we need to study the people we care for. And so I didn't answer your question, but answering your question is it would probably take many hundreds, if not probably in the low thousands, to answer that question. Because what we're really trying to do in answering that question is not just get a population mean difference. In other words, is one group on opioids, are they different? What we're really trying to understand are the responders. Because we all know that there's a group of people who don't respond to opioids. And there's a group of people who do respond to opioids, and if you average that out, unfortunately what you end up with is a null. So what we're really wanting to know is who are the people who get better. Anyway, that's where I'd put my money if I were the government writing checks.
I'm going to suggest it's impossible. You will not see that happen. It doesn't matter. There is no one study that will do it. There is no 1,000 studies that will do it because it's not about the research only. Only a third of the high-quality, double-blind, multi-center, randomized, placebo-controlled trials will be replicated, actually. So you can actually bump the standard up even higher if you want to. And so this is how we spin and interpret data. We do all this stuff to ensure very rigorous information, and then we interpret the data as we want by other forces. And so evidence-based medicine gets thrown aside when it comes to application in those areas. And so the second part of your question is most important. I can't get to the pet issue, so I'll do the second part, which is about how do you communicate the relevance and the importance of this area. I mean, the Pain in America summarized incredibly motivating information of lots of different studies. I mean, just the cost components. And yet somehow it didn't get the impact and the traction, and that's probably the more important aspect. Yes, we always need more research, there's no question about it, but that shouldn't become an excuse for not using the research that we already have to act.
Thank you. One more question, and then we're going to conclude our panel.
It wasn't really a question as much as a comment. There are doctors that are measuring the things that you're talking about, quality of life after pain care, and I have a 5-page thing that I have to fill out every time I see my doctor, and it includes things like what home treatments are you using, your diet, what you're doing with your time, whether you're working or not, whether you're volunteering, whether you're exercising, who you're spending your time with, all those things. How many times a day, how many times a month do you get outside the house? I mean, it's very comprehensive, and I think doctors should be using these kind of things so they could put together metrics about how well their patients are actually doing. And the other thing is that there are ways to objectively measure patients. The word subjective really isn't true when it comes to pain care as much as people think. There was a study, well, not a study, an article put out called Using Objective Signs of Severe Pain to Guide Opioid Prescribing, and it was also by Dr. Forrest Tennant. And it goes through a bunch of things. It has charts and how to, look for someone who's really looking for pain care and not looking for opioids for other purposes.
Thank you.
So can you tell us what doctor is asking you all of those great questions?
Actually,
and what
there's
tool they're using? Is it a routine part of what they do? all
it is
the
a
time in
routine part of what
practice?
they do.
What is it called?
It's a San Gabriel Valley group of doctors, and there's also pharmacists that are involved. My doctor is Dr. Lloyd Costello. Dr. Ananda is also using it.
So what kind of healthcare providers are these? Are they just routine primary care docs? Are they integrative healthcare
Internists
docs?
and pain management.
Interdisciplinary pain management, sort of like similar to what is done at you probably do up at Stanford, where you can ask all those questions, right? Where you get some kind of resources that support the ability to ask those questions.
Yeah, want to commend your docs for capturing that type of information that is meaningful. It does have an impact on your life and using that information. I think the message is that we need more people doing that. Yeah. It's not being done as systematic. Yeah. With regard to truly objective biomarkers, this may be an issue of semantics in the way that objective is used in more of the research field, but there is a strong interest in developing objective biomarkers and markers of pain. We have a great appreciation that pain is a subjective experience. It's whatever you say it is. It's not unlike love, fear, hate, anger, anxiety, depression. We don't have good objective measures yet. We're working on trying to develop those. We've published some of the first papers using brain imaging to develop objective biomarkers. Is that going to see the light of day as a real objective marker? I don't think so. I think we will translate that into an effective clinical tool, but it's going to be several years down the line, and a lot of good science has to be done before we get there. In the meantime, I suggest we rely on what the patients tell us. That's where we're going to get the best information. But once again, just want to circle back. Congrats and props to your docs for collecting that information, and we need more doing that.
Thank you, Chris.
Yeah, I just wanted to, again, thank the panelists, and I think the discussion that we just had and several of the last couple questions really underscores, even though we're not talking about it today, the need for research, but more importantly, for me as a research advocate, it takes a lot for me to say more importantly than that, but then we cannot go by the wayside public education. There is an undertone of pain in our country that's causing our lawmakers not to do something, that's causing large establishments in medical school education not to do something about pain. The stigmatization, the misunderstanding, the misconception, there's something societal in this country that needs to be addressed. And if we don't address that underscore, that tone of what is pain, study it, understand it, and change it, we're never going to have that cultural transformation that we called for. Lawmakers are not going to do what we need them to do. And large institutions are not going to make those changes. And it's really been something that has been largely ignored, but I think one of the cornerstones that needs to be addressed to move this forward.
Let's have a big hand for our moderator and our panel.